And thanks Dr. Sugumaran to arranging this phenomenal seminar to help the students of Government Siddha Medical College at Chennai. As you know, it is a status epilepticus is a life-threatening emergency characterized by prolonged or recurrent seizures without recovery between episodes. The prompt treatment can prevent irreversible neuronal injury, morbidity, and mortality. Disparities in care exist, particularly between high-income countries and low-income, middle-income countries, as well as within the low-middle-income countries themselves. This is the recent guideline just published in January 2025. There are two timelines mentioned. One is called T1, another one is T2. T1, when the seizure activity terminates. T2, when the long-term consequences that might occur because of prolonged seizure that include neuronal injury, alternations in the neuronal networks, or death. The T1 times and T2 times vary based on the seizure you see. In tonic-clonic seizure, which is generalized convulsive tonic-clonic seizure, the T1 is 5 minutes. You call status epilepticus if the seizure lasts more than 5 minutes. And the neuronal damage happens when the seizure lasts more than 30 minutes. Focal seizure with impaired awareness. In that particular category, the status epilepticus is defined when it lasts more than 10 minutes. When the neuronal injury happens, it lasts more than 60 minutes. Absent status epilepticus, you call status epilepticus if it lasts more than 10 to 15 minutes. We do not know at this point how long will it take to cause neuronal injury. That is an important point. If you let this seizure last more than 30 minutes, 60 minutes, it does cause injury to the brain. So it's important to identify and address it then and there. There are multiple definitions have been developed by International League Against Epilepsy. One is early or impending status epilepticus. That is seizure lasting longer than 5 minutes without recovery of consciousness in between the seizures. Established status epilepticus, the seizure do not respond to first-line medication, which is benzodiazepines. We will go into the detail in subsequent slides. Refractory status epilepticus, the seizure continuing after 2 adequately dosed anti-seizure medications. That means benzodiazepines, that is the first one, and second anti-seizure medications that could be levetiracetam, phenytoin, phenobarbital, so on and so forth. Super refractory status epilepticus, seizure lasting more than 24 hours. Then there are 2 other terminologies have been incorporated. One is new onset refractory status epilepticus. There is a subset within the new onset refractory status epilepticus called FIRES. Febrile infection related epilepsy syndrome. That is a subset of onset. Febrile infection precedes 24 hours to 2 weeks. So it is important to elicit the history. The timing of the seizure is important and the response to the treatment. The incidence of convulsive status epilepticus is 9 to 40 per 100,000 people per year. The higher rates are seen in children and older adults. The incidence is higher in low middle income countries than high income countries. The highest age for the status epilepticus is 51 per 100,000 people per year. It's found in infants younger than 1 year. The neonatal seizures, I'm going to briefly mention the latter part of this seminar. Non-convulsive status epilepticus can present as focal motor seizures. non-motor seizures, or absent seizures. The pathogenesis of status epilepticus include either failure of inhibitory pathways mediated by GABA or hyperactivity in excitatory pathways mediated by glutamate. It leads to neuronal damage, cell death, and alteration in brain networks. Seizure lasting longer than 30 minutes represent the beginning of neuronal damage with a self-perpetuating dysregulation. This one assumes the patient is having generalized tonic-clonic seizure. The prolonged seizure leads to internalization of GABA subunit A receptors, reducing synaptic inhibition as well as responsiveness of benzodiazepines. Very important, when you give benzodiazepine to halt the seizure, you can repeat one more time. Subsequent doses does not help because it acts on the A subunit of GABA, which is not available because it's internalized. Status epilepticus leads to increased epinephrine and norepinephrine levels, promoting peripheral vasoconstriction to enhance continued perfusion and oxygenation of the muscles and brain. It causes cyanosis and decreased oxygen saturation. Longer the seizure continues, the increases the risk of compensatory failure, resulting in decreased perfusion, oxygenation, and hypoglycemia. The high rate of decompensation with cardiovascular collapse happens if the seizure lasted 20 to 40 minutes unabated. The differential diagnosis, one should differentiate the status epilepticus from dystonia and myoclonus. They also look very similar to status epilepticus. Another category you will come across is psychogenic non-epileptic seizures. In children, not that much. Only in adolescent adults, they can have psychogenic non-epileptic seizures. There are specific things you can differentiate clinically, but the final diagnosis by EEG. EEG would be normal in movement disorders, and psychogenic non-epileptic seizures in status epilepticus, it will be very different. How do you diagnose psychogenic seizures? It lasts more than 5 minutes duration in individual events. Fluctuating course, waxing and waning, asynchronic rhythmic movements, pelvic thrusting, side to side, head body movements during a convulsion, and close the eyes, ictocrying, recall of items during the event. If it is true seizures, you cannot recall the events. Sometimes, even if there is a significant injury like tongue biting, incontinence, non-stereotyped, flailing and thrashing movements, opisthotonus, even associated injury, does not preclude the psychogenic seizures. The only way to differentiate from status epilepticus from psychogenic seizures by EEG. Status dystonicus looks very similar to status epilepticus, potentially life-threatening, that can be mistaken for status epilepticus. So, EEG is a must. Non-convulsive status epilepticus can present like altered mental status, hallucinations, confusion and coma, motor phenomena, automatism, ataxia and dysarthria, autonomic changes, pallor and vomiting, history of epilepsy, or convulsive status epilepticus. Non-convulsive status epilepticus is associated with neuronal injury and increased morbidity even without clinical seizures. Because the patient has a non-convulsive status epilepticus doesn't mean it will not cause neuronal injury. So urgent intervention is needed. The etiology of status epilepticus are divided into 6 categories: acute symptomatic, remote symptomatic with acute precipitant, progressive encephalopathy, febrile status epilepticus, cryptogenic, or idiopathic. Somebody made a scratch if you do not mind removing it. Acute symptomatic status epilepticus present in meningitis, encephalitis, electrolyte disturbances, sepsis, hypoxia, or intoxication. That accounts for 26%. Remote symptomatic happens in previous CNS injury patient, accounts for 33%. Remote symptomatic with acute precipitant seen in patients with concurrent exacerbating factor, illness or hypoglycemia, accounts for 1%. Progressive encephalopathy, children with underlying progressive disorder, it accounts for 3%, most often seen in underlying genetic disorder or in older individuals. Febrile status epilepticus accounts for 35% of the patients, most often seen in children. Cryptogenic, that means in 15% of the patients you do not know the result. Electroclinical syndromes such as Lennox-Gastaut syndrome, 10% of children with epilepsy present as status epilepticus as their first seizure. Another important thing is 25% of children with epilepsy develop status epilepticus in their lifetime. So everyone with seizure needs to be taught and also give anticipatory guidance that it could happen and how to stop the seizure from becoming status epilepticus. So how to prevent status epilepticus? As a rule, a seizure is easier to stop soon after it begins. When it becomes persistent, it is kind of hard to control the seizure. It's very important. So it is important to abort the seizure before it becomes status. If it becomes more than 3 minutes, I usually get ready to control the seizures right away, even though the guideline says 5 minutes. How do you control the seizures? By intranasal diazepam, rectal diazepam, intranasal midas, oral dissolving tablets of clonazepam, and buccal midas. I'm going to give the details. The diazepam available as a rectal gel as well as nasal spray. As you can see, Diastat, brand name Valtoco. These are the doses. It's kind of hard for you to remember. I am going to load this seminar so that you can watch it over. And midas can be given as a nasal spray and also in buccal route. Clonazepam is also often used, but it's an off-label use. For the label use, that means approved by FDA, is diazepam and midas in preventing the seizures at home. What are the problems with the rescue medications? Because you need to teach the caregivers how to give the medicine, what is an appropriate dose. The most common side effect is sedation, especially when combined with opioids in adults, because some of them may have pain medication prescribed, along with if they give any of these benzos, it can cause respiratory depression. In newborns, if they are already in phenobarb or whatever, that can cause respiratory depression, and after ingestion of alcohol in adults or older pediatric patients. This particular study I wanted to show it to you. It was published in 2012 in New England Journal of Medicine. It's famously called RAMPART trial. That means rapid anticonvulsant medication prior to arrival trial. That means these patients were treated with intramuscular versus intravenous therapy in the pre-hospital status epilepticus. They compared two medications, intramuscular midas and IV lorazepam. There are two groups, 13 to 40 kilos. They gave 5 milligram intramuscular midas and 2 milligram IV lorazepam. If the weight is more than 40 kilos, 10 milligram intramuscular midas and 4 milligram IV lorazepam. Sometimes it's kind of hard to get an IV in the field or at home. So the emergency medical service people, they use midas with lorazepam. It's a non-inferiority trial. As you can see, there is no significant difference between midas and IV lorazepam. That means you do not have to have an IV to give the medicine. The one more thing you need to look at, intramuscular midazolam, which was successful in aborting seizure in 73.4% versus IV lorazepam, 63.4%. Even though there is a difference, it's not statistically different because this particular study was done to show non-inferiority over IV lorazepam because that is our standard. So in turn, you can give intravascular midas. That also it is possible the higher improvement with the intravascular midas, maybe there is no delays. Immediately they gave a shot. IV lorazepam, you got to have an IV. There is a delay in starting the medication. So how do you manage in established status epilepticus? ABC first, airway, breathing, and circulation. Second, suctioning of secretions or vomitus. When you do suctioning of secretions or vomitus, make sure the patient's neck is turned to the side. Otherwise, they may or can aspirate. And medication for prolonged seizures, monitor the vital signs, including saturation, blood pressure, and heart rate. Second, get an IV access because to draw labs and also to give the medication. Identify the treatable causes of seizures, like hypoglycemia that can be easily treated by giving glucose. Hyponatremia, low sodium can cause seizure that can be treated with 3% saline. Hypercalcemia by calcium chloride or calcium gluconate. Those are all easy fixes in patients with status epilepticus. So always checks glucose, sodium, and calcium. The next steps, urine toxicology, especially if you think they took some abusable drugs. So now, since it's more common, adults and adolescents, it is, if you suspect, check the urine toxicology screen. Metabolic studies, as I mentioned, glucose, sodium, and calcium. EEG needs to be hooked up as soon as possible because that confirms the diagnosis of status epilepticus. Neuroimaging, typically we do while we are doing controlling the seizures, also immediately aftermath. If you suspect meningitis, start antimicrobials. You do not wait for the test results. If you can get a spinal tap before antimicrobials is good, but do not wait for even spinal tap. Go ahead and give the antimicrobials. I will give you a suggestion what kind of antimicrobials you should choose in a suspected CNS infection. Leukocytosis could suggest underlying infectious etiology. Sometimes demarginalization alone can cause leukocytosis. Subtherapeutic levels of anti-seizure medication in an established seizure patient. Urine and serum toxicology screen. This is the article published in Pediatric Review 2023 and suggests complete blood count, electrolytes, glucose, anti-seizure medication level, especially if the patient already on anti-seizure medication, urine toxicology, spinal tap, neuroimaging, and electroencephalogram. Okay, let's walk through one by one. The upcoming slides are very, very important in children and adults, and I'm going to have a separate one for pregnant women and also for the newborns because they are a little different. The first 5 minutes, give IV lorazepam, which is available. That is the number one drug to go into. If you don't have IV lorazepam, the second one is intramuscular midas. In the United States, these medications are available in CC. But if you do not have, one can use IV diazepam. That's not preferable if you have lorazepam. So airway, breathing, and circulation, blood glucose, if it is low, give IV D50 in adults, in children D25 or D10. In the meantime, assess the patient for stroke using stroke screen. If the seizure doesn't stop with the first dose of benzo, give second dose of benzo. If it is midas, you have to give 10 milligram 2 times or 5 milligram 2 times based on the weight. Lorazepam, 4 milligram and 4 milligram. That is the max, but the dose is 0.1 per kilo. The second dose of benzo did not control the seizure. Give the second line anti-seizure medication. There are 5 recommended. You can choose from. The number one being levetiracetam, 60 per kilo. Please go with one dose. If you read some articles, they'll say 40 to 60. You don't have to oscillate. The dose is 60 per kilo, max of 4.5. IV phenytoin, 20 per kilo, max of 2.5. Valproic oxide, 40 milligram per kilo, max of 3. Lacosamide, 6 milligram per kilo. IV phenobarb, 20 per kilo. During this time, make sure airway breathing is secure, always very important. And CT head, CT angiogram, and perfusion. If the stroke score is more than 4, at that point, activate the stroke team if you have it. Antibiotics, antivirals, and adjunctive agents needs to be given. In alcoholic, giving Thiamine is not a bad idea. If the patient is still seizing, then you divide into two groups, whether the patient is responsive or unresponsive. If the patient is responsive, give second dose of second line anti-seizure medications. Don't use the same. For example, if you use levetiracetam, this time use IV phenytoin. The patient is unresponsive, you have three choices: propofol, midas, and ketamine. That time the patient needed to be intubated because they already received benzodiazepines and anti-seizure second line anti-seizure medication. Then that point, either they are comatose or this medication made them comatose. So most of these patients get intubated. If the patient is still seizing on it, then you have to load with pentobarb, 10 to 20 milligram, and with the infusion. At this point, you reach out to the specialist, with neurologists and critical care. So how do you select with anti-seizure medication? So I'm going to talk a little bit in detail, but first one, number one, what is available? In most of the United States, levetiracetam is available. And also, if the patient has liver disease, pregnancy, this is the go-to medication. Valproate, if the patient has renal disease, myoclonic status, absence status, valproate is a go-to. Phenytoin is preferred over phenytoin, and avoid combination of valproate and phenytoin. Phenytoin can cause hypotension, especially when you do it rapidly. Phenytoin less side effects than phenytoin. The common acute adverse effects, phenytoin can cause hypotension, cardiac arrhythmias, and somnolence. Valproate, hyperammonemia, hepatotoxicity, thrombocytopenia, and teratogenic. So we don't use in pregnant women and also in children. Lacosamide, more and more used AV block, bradycardia, and hypotension. Regarding antibiotic, if you suspect meningitis, go ahead and give 25 per kilo of vancomycin, max of 2.5, ceftriaxone 2 gram, acyclovir 10 per kilo, 1 dose. I have an evidence in neonates, especially 20 per kilo works much better than 10 per kilo, especially when you suspect. Ampicillin needs to be given if the patient age is more than 50 years or if the patient is less than 1 month old, to cover for listeria. Penicillin allergic patients, Bactrim and Astrionum, and pyridoxine, especially in isoneocytoxicity, in alcoholic patients, thiamine. Does the speed really matter? Yes. Age and etiology are the biggest determinants of outcome in status epilepticus, along with rapidity of control of seizures. So achieving seizure control within the first 1 to 2 hours is a significant determinant of outcome. So what are the initial medication to control the seizures? Midas, diazepam, and lorazepam. If you have lorazepam, that is preferred over midas and diazepam. If you do not have lorazepam, you can either use midas intramuscular or intravenous, or diazepam. All the three drugs can be given intravenously as well as intraosseously. Midas and diazepam available in intranasal formulation, diazepam available as rectal formulation. So when you have an IV access, lorazepam is a go-to, followed by diazepam and clonazepam based on the availability. Intramuscular, if you don't have an IV, midas can be given intramuscular, intranasal, and buccal. Diazepam rectal and intranasal now available. Lorazepam intranasal can be given. The doses are very similar. When to give the second dose of medication? The first dose of benzo needs to be given within 5 minutes. If the seizure fails to stop within 5 minutes after the first benzo has been administered, second dose of the same medications may be given. The benzo, the same dose given. Because of the short duration of action, the second line medications, namely levetiracetam, phenytoin, valproic acid, should be given even when the benzos control the seizure, because the duration of seizure control with benzos are very short. The reason we do benzos first because of the rapidity of action. For the longer control, you need to give the second line medication. So what are the second line medications? The most commonly used medications are levetiracetam, phenytoin, valproic acid. If you look at that one, I use only phenytoin because it's predominantly, or it's only used in the United States. I never used phenytoin in the past 30 years. If levetiracetam fails to halt the seizure, phenytoin, then valproic acid can be added in that sequence. Levetiracetam, phenytoin, and valproic acid. Phenobarbital is a reasonable alternative, but sometimes it's unavailable, ineffective, and also it has lots of side effects, especially if you give after 2 doses of benzos, if you give phenobarb, invariably you'll end up intubating those patients. By the same token, phenobarbital is the first line agent in neonates. Lorazepam has been used, especially in absent status. Lorazepam is a go-to and also more and more commonly used in adults and adolescents and pregnant women. The dose of phenytoin 20 per kilo, the phenytoin dose is the same. Levetiracetam 60 per kilo, phenobarb 20 per kilo, valproate 20 to 40 per kilo. I'm going to discuss 3 trials, very important trials you need to know for 2 reasons: how the entire world is doing or choosing second line, and also how to look at the papers. First one is concept trial, convulsive status epilepticus in children. It was done in Australia and New Zealand. They did 2. One arm received 20 per kilo of phenytoin, not phenytoin. It was infused over 20 minutes. And they did levetiracetam. They gave 40 per kilo, as I told you before. The recommendation or standard guidelines here in the United States is 60 per kilo. But at that time, they did 20 per kilo of phenytoin and 40 per kilo of levetiracetam. That was infused over 5 minutes, the phenytoin over 20 minutes. And I want to explain, they checked different age groups and different kind of seizure. They found a difference in p-value. The p-value usually is significant, not usually, it is significant if it is less than 0.01. As you can see, none of the parameters are significant between these 2 groups, phenytoin group and the levetiracetam. And the further subgroup analysis also did not show anything significant. So come to this interpretation of this trial, concept trial. They found levetiracetam is not superior to phenytoin for second line management of pediatric convulsive status epilepticus. Let's move on to the next one called ECLIPSE trial. It is done in United Kingdom Emergency Department. They also use the same strategy, levetiracetam 40 per kilo over 5 minutes, phenytoin 20 per kilo over 20 minutes. They also did not find any difference between these 2 groups. They concluded the levetiracetam is not significantly superior to phenytoin. But because of rapidity of using, because levetiracetam can be given within 5 minutes versus phenytoin over 20 minutes, the timing is very important in controlling the seizure. So levetiracetam is an appropriate alternative to phenytoin. That's how they concluded that study. Again, published in 2019 Lancet. The third study, very important, it is published from United States, published in 2020. This is a trial, established status epilepticus by age group. It's different from this previous ECLIPSE and concept by 2 ways. Number 1, it compared 3 drugs, levetiracetam, phenytoin, and valproate. It also examined children, adult, and older adults. Let's look at the data. In children, there is no significant difference between all the 3 medications. In adults, there is no difference. Well, even if there is difference, not statistically different. In older adults, you see the valproate work much better than the other two. Even though it's different, but statistically not different. So if any of this, according to ESA trial conclusion, any of these three drugs can be considered as a potential first choice. Most of the time, what determines is what's available and how rapidly you can give to control the seizure. Well, second anti-seizure medication given even repeated, the seizure still persists. You have four choices: midas, propofol, pentobarb, and ketamine. At this point, you got to have a neuro consult. I would say critical care consult too. EEG monitoring needs to be done, meaning continuous EEG need to be hooked up. At this point, there is no consensus on which third line infusion should be used. But one should remember the actions and side effects of the medications. Midas and pentobarb require secure airway because they cause respiratory depression. It also causes significant hypotension. Invariably, on these patients, whenever I start pentobarb, I will have a norepinephrine on board to keep the blood pressure up. Ketamine has less effect on blood pressure and does not require intubation. Propofol infusion rarely used in pediatric patients because of the risk of propofol infusion syndrome. Additional treatments one should consider at this point is starting ketogenic diet, corticosteroids, IV immunoglobulin, especially in fires, IV immunoglobulin followed by corticosteroid works, and vagus nerve stimulation. Let's see one by one. Midas has a favorable hemodynamic profile when compared to other medications. The bad side of it, so it causes tachyphylaxis, means it loses its efficacy after the infusion over 24 to 48 hours. It may deposit into adipose and cause prolonged sedation. Propofol, the good thing is rapid drug clearance, acts fast, clears fast, but it will cause hypertension, myocardial depression, and in children, propofol infusion syndrome. Ketamine is different because all other medications act through GABA, potentiating GABA. Ketamine works through NMDA blockade. Has a favorable hemodynamic profile because it has sympathomimetic effect, increase heart rate, increase blood pressure. But we do not have that much of experience with the ketamine, so can be used, but we do not know. Pentobarbital has been widely used for many years. It has a prolonged half-life. Cardiac depression, bone marrow suppression, ileus can happen with, not can happen, it will happen when you use pentobarbital infusion. So when you have, at this point, the patient is having seizures uncontrolled, the patient needs to have a continuous EEG, adjunctive treatments need to be considered, and look for potential focus that can stop the seizure by removing the tumor or epileptic focus, and diagnostic studies needs to be done, autoimmune, paraneoplastic panels, and imaging for tumor. Okay, let's switch gears. Status epilepticus in newborn. They behave differently. They will not have a convulsive tonic-clonic seizures as we see in children and adults. On the other hand, they will have motor and non-motor movements like automatism, multi-clonic seizures, like twitching movements here and there, epileptic spasm, myoclonus, tonic seizures. Just different. Non-motor like autonomic behavior arrest, sometimes unclassified. So very important to have an EEG. Number one, identify, is it seizure or not? So once you establish or even suspected, number one, check glucose and electrolytes, like what we have seen in pediatrics and adults. In newborn, the first line is pentobarbital. Even the recent trial between pentobarb, I think Livoneo 2 trial, shows phenobarb is better than levetiracetam. Irrespective of the etiology of the seizure, newborn phenobarbital is a go-to. The seizure persists after 15 minutes, give the second dose. If the seizure still persists, give levetiracetam and also dose 20 for pheno, levetiracetam 20 per kilo. That may be the reason he didn't do well, because in adults and children we use 60 per kilo. Whatever, this is the data available. And if it doesn't work, or if the patient is known to have channelopathies, then you can use phenytoin. And one can consider pyridoxine in these patients, even empirically, because it doesn't have a harm. Sometimes pyridoxine dependent seizures, pyridoxine deficiency seizures, especially with maternal hyperemesis gravida, that is, you can try pyridoxine 100 milligrams, it's easy to remember, and look for cessation of seizures. Status epilepticus in pregnancy. There are two kinds: status epilepticus with prior history of epilepsy, and new onset status epilepticus, they call NOSEP. It's caused by the NOSEP, new onset status epilepticus pregnancy, caused by 4 different syndromes. One is post-reversible encephalopathy syndrome called PRES, reversible cerebral vasoconstriction syndrome or CVS, eclampsia, and cortical venous thrombosis. There is a protocol proposal published in 2022. They published multiple studies in pregnancy. I want to show you 2. One is retrospective study. Most of them are case reports. Retrospective study. Another one is prospective study. What really intrigued me was the death rate in the retrospective study was close to 30%. That means 1/3 of the women die because of status epilepticus in pregnancy. This is a prospective study, again showed 27%. It is wrongly, I think it's a typo, but had a poor outcome. So the substantial portion of women suffer from status epilepticus if you don't do it right. How do you do it? Status epilepticus in eclampsia, you do it differently than status epilepticus without eclampsia. In eclampsia, loading dose of 4 or 6 grams over 15 to 20 minutes, followed by 2 grams per hour. I would not consider even intramuscular. At this point, these patients do have an IV. The second line medications are benzos, Lorazepam, diazepam, and midas. And third line is midas, propofol, thiopentol, and ketamine. What is important is, as soon as the patient have, in addition to MAG, you induce the labor if fetal-maternal conditions are stable. If fetal-maternal or non-reassuring, then cesarean delivery is recommended, because not only it controls the seizures, because you remove the placenta, the eclampsia gets cured too. In a pre-existing epilepsy, you treat similar to what we have done in children and adults. Benzos are the first line, midas, lorazepam, and diazepam, followed by levetiracetam, phenytoin, phosphenytoin, then the infusions, midas, propofol, thiopentol, ketamine, like what we discussed before. If the seizure lasts longer, termination of pregnancy needs to be considered, because they will be exposed to multiple seizure medication that can be injurious to the newborn, or immediately control the seizures and deliver the baby. This is a clinician survey done in obstetrics docs. Find out which medication they used. The second line medications most commonly used is levetiracetam, like what we use in adults and children. If the levetiracetam fails, the second go-to they do, it's interesting, they go to lacosamide, 60% of them, and 20% of them phosphenytoin. If the second medication also didn't control the seizure, they 60% go to midas and 36% go to propofol. I just wanted to throw in, this is the way the obstetrician practice in the United States. Outcome after status epilepticus: benzos terminate status epilepticus in 70% of the cases. The second line medication is effective. Those 30%, another 50% can be controlled. The timing is important. Second most important is Give adequate doses. There are studies showing most of the people don't give adequate doses. As a result, the seizures prolong. Almost 3 to 6% of the patients die during acute hospitalization. The long-term mortality, meaning the patients discharged home, they die even when they go home, 4 to 17%. The outcome depends on the duration of seizure and the underlying etiology. And also you expect high mortality and high morbidity independent of seizures in underlying etiology, like near drowning, higher mortality and morbidity. Sepsis, hemorrhagic shock, aspiration or prolonged mechanical ventilation. These are really, really high risk group. Refractory status, meaning benzodiazepine failed to stop the seizure, second anticonvulsant failed to stop the seizures. The mortality goes to 32%. Look at that one, 3 to 6% to 32%. Even though survival have a significant neurodeficit, motor deficit, behavior and developmental problem, and new onset epilepsy just from status epilepticus. Those who had a status epilepticus, they can have recurrent seizures in 16 to 50%. So it's very imperative to control the seizures, identify and control the seizures as quick as possible. It can leave focal deficit, behavioral disorder, and cognitive disorder. 1/3 of the patient develop cognitive and behavioral problems after status epilepticus. Younger the age, duration of the status epilepticus, the strongest predictors of worse neurocognitive outcome. So close monitoring of the patient development, especially in children, behavior and cognition by both neurologists and the pediatrician after status epilepticus is very essential. And also I want to make a point because highest incidence status epilepticus happen in children less than 1 year. So take home points. Status epilepticus is a neurologic emergency. Timely intervention prevents seizures becoming status epilepticus. Very critical. Check glucose, calcium, and serum sodium. Do not forget the diagnosis of meningitis if you suspect. Do not delay antibiotics. Even if you have not done a spinal tap, antibiotics, you can do the spinal tap later. Because the availability of PCR will still identify the bug that is causing meningitis. Control the seizure within 30 to 60 minutes. Obtain a neurologic consult, neuroimaging appropriate one. And if you suspect stroke, alert or activate the stroke group. And continuous EEG for status epilepticus is a must to make the diagnosis and also to control the seizures adequately. This concludes this seminar. So if you have any questions, please go ahead and ask or type it.